Bismillahirrahmanirrahim. Quote of the day: Nothing will work unless you do. Today, the topic of my presentation is hypertension, and I'm presenting it under supervision of my professor, Dr. Sarawak. Learning outlines: what is hypertension, its categories, preventive strategies, treatment, recent updates, and MCQs in the end. Learning outcomes: by the end of this presentation, participants will be able to describe different categories of hypertension, signs and symptoms, prevention, and control. What is hypertension? It is also known as high blood pressure, long-term medical condition in which blood pressure in the artery is persistently elevated. It usually doesn't cause symptoms, but the long-term hypertension is a major risk factor for stroke, coronary artery disease, heart failure, atrial fibrillation, peripheral arterial disease, vision loss, chronic kidney disease, and dementia. WHO key facts about hypertension: it is that an estimated 1.28 billion adults aged 30 to 79 years worldwide have hypertension, and two-thirds they are living in the low and middle income countries. An estimated 46% of adults with hypertension are unaware that they are suffering from this condition, and less than half of adults with hypertension are diagnosed and treated. Approximately 1 in 5 adults with hypertension have it under control, and it is a major cause of premature death worldwide. One of the global targets for NCD is to reduce the prevalence of hypertension by 33% between 2010 and 2030. Rule of halves. As we all know that it is like a iceberg disease that only half have been diagnosed. Only half of those diagnosed have been treated. Only half of those treated are adequately controlled, and thus only 12.5% overall are adequately controlled. So this is the rule of halves. Categories: normal, elevated, hypertension stage 1, hypertension stage 2, hypertension tensive crisis. Now let's talk about each one by one. Normal blood pressure in this, the systolic blood pressure is 120 mmHg and diastolic is 80 mmHg. Clinical implication: minimal risk for cardiovascular diseases, maintained healthy lifestyle to preserve normal BP, and recommendation is control regular physical activity, follow a balanced diet such as DASH diet. Now, elevated BP is categorized with systolic BP as 120 to 129 mmHg and diastolic BP less than 80 mmHg. Clinical implications include increased risk of developing hypertension. Early intervention can prevent progression. Again, the recommendations are lifestyle modification and regular monitoring of blood pressure. Then comes hypertension stage 1, in which systolic BP is 130 to 139 and diastolic BP is 80 to 89. The clinical implications include moderate risk for cardiovascular events because lifestyle changing possible medications for certain individuals. Recommendations are again lifestyle modification, diet, physical activity, weight management. But here in this stage, we consider pharmacological treatment for high risk patients. Then comes stage 2, in which the systolic BP is 140 mmHg or higher, and diastolic BP is 90 mmHg or higher. Clinical implications is that a high risk for cardiovascular and renal complications. Pharmacological treatment is typically required in this stage, and recommendations include combination of lifestyle changes and medication, regular follow-up, and BP monitoring. Hypertensive crisis, and this systolic BP is higher than 180 mmHg, diastolic BP is higher than 120 mmHg. There are two types of hypertensive crisis, that is hypertensive urgency, in which there is severe elevation without acute target organ damage. Hypertensive emergency, in which there is severe elevation with evidence of acute target organ damage, and clinical implication that it requires immediate medical attention. There are other considerations like white coat hypertension, in which elevated BP in a clinical setting but normal at home requires ambulatory BP monitoring for accurate diagnosis. Masked hypertension with normal BP in clinical setting but elevated at home also requires BP monitoring, ambulatory BP monitoring for proper diagnosis and management. Secondary hypertension, in which hypertension is due to underlying condition like renal disease, endocrine disorders. Identifying and treating this the underlying cause in this type is crucial. Risk factors, it is broadly they are divided into non-modifiable and modifiable. Non-modifiable risk factors, and this a risk factor is that cannot be reduced or controlled by intervention, like age, gender, race, ethnicity. Modifiable risk factors are those that can be reduced or controlled by intervention, like physical inactivity, tobacco use, alcohol use, and healthy diets. Sign and symptoms, we all know that it is commonly characterized by dizziness, lightheadedness, blurred vision, rapid heart rate, lack of concentration, fatigue. Then comes levels of prevention. Here we can see that there are four levels of prevention: primordial, primary, secondary, and tertiary. In primordial prevention, we prevent the development of risk factors. In primary prevention, this is preventing the onset of disease. Secondary prevention, we all know it is early detection and treatment, and tertiary prevention is reducing complications and improving quality of life. So, primordial prevention, the strategies include promote healthy environment, that is policies to reduce salt and trans fats in foods, urban planning to promote physical activity like creating parks, pedestrian pathways, early health education, that is implementing programs in school to educate children on healthy lifestyle choices. Then comes primary prevention, the objective of which is to prevent the onset of hypertension in at-risk individuals. Strategies include lifestyle modification. It has a major role in primary prevention, which includes DASH diet, which is rich in fruits, vegetables, whole grains, and low-fat dairy, reduce salt intake, that is, it should be less than 5 grams of salt per day. Regular physical activity, that is at least 150 minutes of moderate intense aerobic activity per week. Weight management is to maintain a healthy body weight, that is BMI between 18.5 to 24.9 kg per meter square. And limiting alcohol intake, that is up to one drink per day for women and two for men. Dash diet, it emphasizes fruits, vegetables, whole grains, low-fat dairy, lean meat, and nuts. Benefits are shown to significantly lower BP and improve overall cardiovascular health. This is the dash diet that there should be 4 to 5 servings per week of nuts, seeds, and legumes, 6 to 8 servings per day of whole grains, 4 to 5 servings per day of vegetables, fruits. There should be 4 to 5 servings per day, and 2 to 3 servings per day of fat-free, low-fat dairy, 2 to 3 servings per day of fats and oil, and less than 5 servings per week of sweets, and less than 6 servings of lean meats, poultry, eggs, fish per day. So it emphasizes on feeding low-calorie vegetables, fruits, and lean proteins, and it recommends to avoid salt, added sugars, and fat. Population approach, the aim is to reduce average risk level in the entire population. The strategies include public health policies, community interventions, education campaigns, examples reducing salt intake at the national level to food industry regulations. Individual risk approach is aim is to identify and manage high risk individuals. Strategies include personalized intervention, targeted screening, treatment. Examples include providing individualized treatment plans for patients with high BP. Then comes secondary prevention. The objective is to early detection and management of hypertension to prevent complications. Strategies include screening and diagnosis, regular BP monitoring for adults aged 18 and older, home BP monitoring for individuals with high BP, that is 130 to 139 systolic, and diastolic, that is 85 to 89. Pharmacologic interventions, antihypertensive medications like AC inhibitors, ARBs, calcium channel blockers, thiazide diuretics. Combination therapy often required for effective control. Then tertiary prevention, we all know that its objective is to reduce complication and improve quality of life. The strategies include comprehensive management, like control of comorbid conditions like diabetes, hyperlipidemia, kidney disease, continued emphasis on lifestyle modification, patient education and support through self-management programs, like teaching medication adherence and lifestyle changes, support groups providing emotional and social support. And the recent updates about the tertiary prevention includes advanced therapies like use of renal denervation and bioreceptor activation therapy, resistant hypertension, and integrated care models, which includes a multidisciplinary approaches, including primary care, cardiology, nutrition, and mental health. So it all has a big role in tertiary prevention. Population strategy, we have already discussed. It is directed at the whole population, respective individual risk levels, and goal is to shift the community distribution of BP towards lower levels of biological normality, and it involves multifactorial approach like nutrition, weight reduction, exercise, promotion, behavioral changes, in health education. Uh, in population strategies to target the weight reduction, that is BMI less than 25 kg per meter square, exercise promotion that is greater than 150 minutes per week of moderate physical activity, behavioral change like stress reduction, smoking cessation, health education, and self-care. High-risk strategy directed towards people at risk of having hypertension. Aim is to prevent attainments of level of BP at which institution of treatment will be considered. The approach is appropriate if risk factors occur with very low prevalence in community since clustering of hypertension occurs in family. So individual at risk can be identified with family history of hypertension taken by BP from childhood. Complications of high BP include, that if brain is affected, then it can be presented as stroke, hypertensive encephalopathy. If a retina of eye is involved, then it is characterized by hypertensive retinopathy, and then if heart is involved, MI, hypertensive cardiomyopathy, and ultimately leading to a heart failure. And if kidneys are involved, then it can be presented as hypertensive nephropathy, chronic renal failure, then pregnancy-induced hypertension, gestational hypertension, and pregnancy-induced hypertension is a development of new hypertension in a pregnant woman after 20 weeks of gestation without the presence of protein in the urine or the vital signs of preeclampsia. Gestational hypertension is defined as having a BP greater than 140 by 90 on two occasions at least 6 hours apart. Risk factors include maternal cause like obesity, mothers under 20 or over 40, past history of diabetes mellitus, hypertension, renal disease, pre-existing hypertension, thrombophilia, and pregnancy factors are multiple gestation like twin triplet, placental abnormalities, hypoplacentosis, placental ischemia, family history. Treatment, there is no specific treatment, but is monitored closely to rapidly identify preeclampsia life-threatening complications, which is HELLP syndrome eclampsia. Drug treatment options are limited as many antihypertensives may negatively affect the fetus. However, methyl dopa, hydralazine, levodopa are most commonly used for severe pregnancy hypertension. Coming to recent updates, this is an article titled as Diet Approaches to Stop Hypertension, that is diet and blood pressure reduction in adults with and without hypertension, systematic review and meta-analysis of RCTs. According to it, DASH diet is recognized as an effective diet intervention to reduce BP. However, RCT is investigating the DASH diet mediated BP. There are significant methodological and clinical differences. And the purpose of this study was to comprehensively assess the DASH diet effect on BP in adults and without hypertension, accounting for underlying methodological and clinical confounders. And according to it, it was concluded that hypertension status did not modify the effect of on BP reduction, but diet when compared with a controlled diet reduced systolic BP levels to a higher extent in trials with sodium intake greater than 2400 milligram per deciliter per day than in trials with sodium intake less than 2400 milligram per day. Whereas both systolic BP and diastolic BP were reduced more in trials with mean age less than 50 years than in trials of older participants. The quality of evidence was rated as moderate for both outcomes according to the grading of recommendations, and the adoption of the DASH diet was accompanied by significant BP reduction in adults with and without hypertension, although higher daily sodium intake in younger age enhanced the BP loading effect of the intervention. Then we have this as another article that is non-pharmacological management of hypertension. And according to it, lifestyle modification that effectively lower BP are increased physical activity, weight loss, limited alcohol consumption, relaxation techniques of yoga, acupuncture, Tai Chi, mindfulness-based stress reduction program, air pollution of the surrounding air is linked with poor health outcome, major contributor to global burden of disease, and the fine particulate matter is strongly associated with cardiovascular morbidity, mortality, short-term PM exposure, hours to week increases the likelihood of adverse cardiovascular events, including MI, stroke, heart failure, long-term exposure multiplies the risk. So non-pharmacological methods should be initiated early phase of disease and should be continued with medication. Another article titled as Effects of Lifestyle Modification on Patients with Resistant Hypertension Results of Trans RCT. According to all the lifestyle modification journey affecting lowering BP among patients with unmedicated hypertension and those with treated with one or two hypertensive agents, the value of exercise and diet for lowering BP in patients with resistant hypertension is unknown. And in this study, 40 patients with resistant hypertension were randomly assigned to a 4-month program of lifestyle modification, that is C-Life, center-based lifestyle intervention, including dietary counseling, behavioral management, exercise, single counseling session, providing standardized education and physician advice. Primary endpoint was clinical systolic BP. Secondary endpoints include 24-hour BP and select cardiovascular disease biomarker, including baroreflex, high frequency heart rate vulnerability, and pulse wave velocity to assess atrial stiffness and left ventricular mass to calculate left ventricular structure. And between group comparisons revealed that the reduction in clinic systolic BP was greater in sea life compared with SEPA. 24-hour ambulatory systolic BP was reduced in sea life. So diet and exercise can lower BP in patients with resistant hypertension. A 4-month structured program of diet and exercise as adjunctive therapy delivered in a cardiac rehabilitation setting results in significant reduction in clinic and ambulatory BP and improvement in selected cardiovascular disease biomarkers. So coming to MCQs, MCQ number 1. A public health department is implementing a community-wide program to reduce the incidence of hypertension. The program includes policies to reduce salt content in processed foods, urban planning to encourage physical activity, and educational campaigns in schools. Which level of prevention is the public health department primarily focusing on? Primary prevention, secondary prevention, tertiary, primordial, or quaternary prevention?
D.
Yes, primordial prevention. MCQ number 2. A 45-year-old patient with high to normal BP, that is 130 to 139, 85 to 89 diastolic, is advised by the physician to monitor their blood pressure at home regularly and return for follow-up visits every 6 weeks. Which level of prevention is being applied in this scenario? Primary prevention, secondary prevention, tertiary, primordial, quaternary.
C.
B is the right.
D.
B is the right answer. MCQ number 3, 55-year-old woman with hypertension is follow the DASH diet, engage in regular physical activity, reduce her salt intake, and limit alcohol consumption to manage her BP. Which aspect of hypertension management is being emphasized in it? Pharmacological intervention, surgical intervention, lifestyle modification, genetic therapy, stress reduction techniques.
C.
C. Yes. MCQ number 4. A community health survey reveals that only half of individuals diagnosed with hypertension are aware of their condition. Among those aware, only half are receiving treatment, and among those treated, only half have their BP under control. During the survey, 60-year-old man is found to have a BP reading of 145 by 95 mmHg. According to the rule of halves and based on his BP reading, which category of hypertension does the 60-year-old man fall into, and what is the primary issue highlighted by the rule of halves? Hypertension stage 1, lack of awareness among hypertensive individuals. Hypertension stage 2, inadequate treatment among diagnosed individuals. Hypertensive crisis, poor control of BP despite treatment. Elevated BP, high prevalence of undiagnosed hypertension. And hypertension stage 2, insufficient control of BP in treated individuals.
C.
B is the right option. B is the right option. We can see the readings of the BP, they do not fall into a hypertensive crisis, so it is hypertension stage 2. And according to the rule of House, it is inadequate treatment among a diagnosed individual. MCQ number 5, a 45-year-old man visits his primary care physician for a routine checkup. His BP readings over the past month average 130 by 84 mmHg. He has no symptoms and no significant medical history. The physician discusses the importance of lifestyle modifications to prevent the progression of his condition. Based on his average BP readings, into which category of hypertension does this man fall? Normal BP, elevated BP, hypertension stage 1, hypertension stage 2, or hypertensive crisis? Anyone?
A.
C. C is the right option, yes. MCQ number 6, 30-year-old male with history of high cholesterol and positive family history of hypertension comes to you for routine checkup. He's also smoker for the past 5 years. Which intervention will have the most impact in the prevention of hypertension? Increase fiber diet, increase vitamin intake, stop smoking, screening the family history, reducing cholesterol.
C.
Yes, C is the right option. MCQ number 7. They are screening a 60-year-old man for the first time. His untreated hypertension, that is 168 by 106, and BP has been elevated on at least 3 occasions. There is currently no evidence of target organ dysfunction. From a therapeutic perspective, what is the best initial approach? Initiating treatment with 25 mg of hydrochlorothiazide, considering initiating treatment with a two-agent combination pill, delaying pharmacological intervention, and treating with salt restriction, increasing fiber diet or routine exercise, increase multivitamins. B is the right option.
B.
MCQ number 8, hypertension is the leading cause of coronary heart disease and stroke. There are many preventive strategies for controlling hypertension. Regarding nutrition perspective, which type of diet plan is advised? Dash diet, intermittent fasting, keto diet, vegetarian diet, high fiber diet.
A.
A is the right option. MCQ number 9, 40-year female having BP reading at home, uh, high BP reading at home, but during the visit of doctor screening, the reading is normal. Which type of hypertension is this? White coat hypertension, mild hypertension, sustained, pregnancy-induced, stage 2 hypertension. Very easy MCQ.
A.
A. The right option.
A.
Last MCQ, 35-year-old woman with a family history of hypertension visits a community health clinic. She has a normal BP readings but is considered about a risk of developing hypertension in the future. The healthcare provider discusses several strategies to prevent the onset of hypertension. Which of the following studies primarily presents a primary prevention? Conducting regular community BP screenings, prescribing antihypertensive medications to manage current BP, implementing policies to reduce salt content processed food at a population level, advising the patient to adopt a diet that engage in regular physical activity, monitoring the patient's BP and ambulatory BP monitoring.
D.
Yes, D is the right answer. This is key of MCQs, and this is the YouTube link of this presentation. And thank you.
Thank you very much, Dr. Meha. Very nice presentation. As far as the definition of hypertension, management, and the long-term follow-up is concerned, in order to decrease the risk of complications, there are many different guidelines that are available. And the most practiced guideline is about JNC 10. That is the latest version of Joint National Committee guidelines of version 10. These guidelines are mostly agreed upon and they are mostly followed. So, as you have already described about the DASH diet and the follow-ups, etc., it is very important to know that the guidelines help us to decrease the prevalence of hypertension in Pakistan, especially in our adolescent and adult population. It is a very common phenomenon. There are certain risk factors. We know we are mostly talking about the essential hypertension. However, there are other risk factors like use of certain drugs that can lead to hypertension. Secondary hypertension is especially because of the renal artery stenosis is one of the cause that is very common in our population. Lot of work has been done on diet management, and the diet, as you have shown, is evident that it has decreased the risk of hypertension. So these are few important things that I have added. Please add a slide on JNC 10 classification of hypertension. I have shared the guidelines in the group too. So thank you very much and Allah Hafiz.
Okay, thank you.
Allah Hafiz.
Hafiz, ma'am.